خالد يوسف هيتكلم على الرير اند بات ات از ذير من نقطه ثانيه اللي هي ريزيستنت تو ثايرويد هرمون. اتفضل دكتور خالد.
ثانكس بروف فاليا، ثانكس بروف تامر. طبعا صعب جدا الواحد يتكلم بعد المحاضره الرائعه بتاعت الدكتور فريد. الدكتور فريد من الناس البايونيرز في البرزنتيشن والتبسيط الموضوع. but I will try. So my presentation about resistance to thyroid hormone from basic science to clinical practice in Thyroid 13. Let's start by this thyroid function test report. A patient presented with elevated free T3, with elevated free T4, and normal TSH, non-suppressed TSH. What is the best next step in the management of this patient? يلا نفكر نعمل ايه للمريض بتاعنا ده. MRI pituitary, dynamic testing, alpha subunit. What is the best next step in the management of this patient? The most important next step is to repeat thyroid function test. If you see a patient like our patient, like this case, please repeat thyroid function test, the first step. I will start from the beginning. The concept that individual could be resistant to their endogenous hormone was first advanced in 1942 by Fuller-Albright. Fuller-Albright described the first case of resistance syndrome, which is pseudo-hypoparathyroidism, or what is known as Albright hereditary osteodystrophy. In this patient, he found that the patient is biochemically hypoparathyroidism, hypocalcemia with hyperphosphatemia, but the BTH is not low, it is elevated. Later on, in 1967, Samuel Refetoff described the first cases of resistance to thyroid hormone in two siblings, and this paper is published in GCEME. He found that the patient have a signs suggestive hypothyroidism, diffimutase, goiter, delayed bonage. This is the manifestation of congenital hypothyroidism, but surprisingly, thyroid hormone was elevated. Free T3 and free T4 is elevated. So he suggests that this is a syndrome of reduced target tissue responsiveness to thyroid hormone. As I mentioned previously, let's start from the basic science. Basic science is very important, as we know that the thyroid gland produces two very important hormones, thyroxine and the triiodothyronine, T4 and T3. Of course, we know that T4 is the predominant form secreted by the thyroid gland, but T3 is considered the most active form and also binds with much higher affinity to the nuclear receptors. In the periphery, by deiodinase enzymes, the two hormones undergo deiodination, giving rise to other thyronines. In the absence of active hormone, in the absence of active T3, the receptors associated with core processor will inhibit chromatin transcription. While upon binding to thyroid hormone, T3 will bind to thyroid hormone receptor in the nucleus. They release core processor bind coactivator and stimulate transcription of this gene, forming messenger RNA. And this lead to a new protein formation, which lead to activity of the target cells. In the heart, leading to increased heart rate, hypertrophy. In the bone, leading to gross maturation. In the liver will lead to cholesterol synthesis and so on. But we must know that there are two types of thyroid hormone receptors, thyroid hormone receptor alpha and beta, which are encoded by two different genes, and each gene represented in a specific chromosome. And also thyroid hormone receptors alpha and beta have a subtypes alpha 1 and alpha 2, beta 1 and beta 2, and so on. And each one has a specific organ. So deficiency or defect of these genes will lead to a variant phenotype manifestation. So there are syndromes, not one syndrome with impaired sensitivity to thyroid hormone according to the pathway of thyroid hormone action. Thyroid hormone action to act will pass into 3 steps, 6 steps. Defect in any 3 steps of it will lead to a specific syndrome. The first one الثيروid hormone T3 and T4 to enter cytoplasm need a specific transporter. The most important one is monocarboxylate transporter 8, MCT8. So if there is a defect in this transporter leading to thyroid hormone cell membrane transport defect, which is presented usually by a male with severe psychomotor retardation, hypothyroidism in a level of the brain, but peripheral tissue complaining from hyperthyroidism, and has a unique thyroid function test. Free T4 is low, free T3 is elevated with non-suppressed TSH, but TSH may be normal or slightly decreased. This is a unique for thyroid hormone cell membrane transport defect. Free T3 is elevated, free T4 is low, TSH is normal or slightly low. Another defect in the deiodinase enzyme, if there is a deficiency of some deiodinase enzyme 1, 2, or 3, leading to thyroid hormone metabolism defect, and in this case, the patient usually presented by growth delay, muscular dystrophy, hearing impairment, and azoospermia. This is a very important. And also has a unique thyroid function test. Free T4 is elevated, free T3 is low, and the TSH is normal or slightly increased. And the most important syndromes is thyroid hormone action defects. And actually, this is not a one syndrome. It has 3 syndromes. The first one, which is the most classical form, which is resistant to thyroid hormone beta due to the mutation in the beta gene. And another one, if alpha gene mutation in resistant to thyroid hormone alpha. And if the same scenario of resistant to thyroid hormone beta, but after doing genetic study, it reveals no abnormality, so it is called non-TR RTH. I will discuss each case, but a specific discussion about the last one. Let's start by thyroid hormone cell membrane transport defect. It is X chromosomal linked defect due to the defect in the MCT8 gene, what is known as previously Allen-Herndon-Dudley syndrome. This case is described in 1944, but genetic defect just discovered in 2004. This is usually a male with inability to talk or walk and increase the metabolism with poor weight gain. Actually, this patient presented by severe psychomotor retardation, presented by severe hypothyroidism in the neural system. But in the peripheral system, the patient presented by peripheral tissue hyperthyroidism, severe tachycardia, very low body mass index, very low body weight, decrease in muscle volume, 6 hormone binding globulin is elevated. As we mentioned, this is X chromosomal linked, so it only appears in the males. And also, the thyroid function test is unique for this syndrome. Free T4 is low, free T3 is elevated, reverse T3 is low, and the TSH is normal or slightly low. How to treat this genetic disorder? Usually symptomatic treatment, symptomatic therapy by intensive physical and cognitive therapy has been shown to have a positive influence on the degree of a neurological impairment. Also, we can use feeding tube is often used to prevent aspiration. Dystonia can be treated as any neurological dystonia by anticholinergics, L-dopa, carbamazepine, and baclofen. But in this case, thyroxine T4 is low, so we can replace it by supraphysiological dose of levothyroxine, which is effective in improving nutrition and avoid fats. And the dose of levothyroxine is titrated to bring T4 above the upper limit of the normal. But as we know, as we mentioned previously, T3 is elevated, and the T4 will be converted to T3 via deiodinase. So we must block this conversion by prescribing propylthiouracil 3 times daily. But the dose of propylthiouracil usually 3-folds that used in ordinary thyrotoxicosis. Another experimental drugs, which is DETBA treatment, which is thyroid hormone analog, which may bypass the molecular defect by using alternative transporter. This drug improve in nutrition and the weight gain of this syndrome, but have a little improvement in neuroconjunctive function. And lastly, triac and tetrac. Triac, which is a metabolite of T3, tetrac, which is a metabolite of T4, but this drugs is not FDA approved yet. Another very important disorder, which is thyroid hormone metabolism defect. As we know that T4 is a pro-hormone that is activated by the iodinase type 1 and type 2 to the active hormone T3. T4 also is inactivated by the iodinase 3 and D1 to form reversed T3. The most important aspect that each tissue adjusts the amount of T3 or reversed T3 in the intracellular compartment by regulation of D1, D2, and D3. So a deficiency in the iodinase alters the formation of the active hormone and results in syndrome of thyroid hormone metabolism defects, leading to increased free T4, low free T3 with normal or slightly elevated TSH. This is very important. T3 is low, T4 is elevated, TSH is mildly elevated or normal. The most common clinical picture of thyroid hormone metabolism defect, usually growth retardation, photosensitivity, muscle weakness, impaired hearing, hypoglycemia, and infertility, azoospermia, due to the azoospermia. And of course, the treatment is very simple in this case scenario because T3 is the active hormone. We can just replace T3 by lioshyronine, cytomel. And the dosage for the adults is 50 microgram twice daily, and we can add selenium supplementation. Resistance to thyroid hormone, this is a classical form of resistance to thyroid hormone. Before detection of gene defects in thyroid hormone, patients with resistant to thyroid hormone were classified on a clinical grounds alone to two types: generalized resistance to thyroid hormone. In this scenario, the free thyroid hormone is elevated with non-suppressed TSH, and there are resistance to thyroid hormone in a level of the pituitary and in the level in the peripheral tissue. So the patient usually euthyroid because there is a resistance in the peripheral tissue. Another case, which is pituitary resistance to thyroid hormone, in this syndrome, free thyroid hormone is elevated with non-suppressed TSH, resistance only in the pituitary region. In the peripheral tissue, there is no resistance, so elevated thyroid hormone will causing a manifestation of thyrotoxicosis, tachycardia, and so on. The incidence of resistance to thyroid hormone beta, 1 per 50,000 live births. So it is not a very rare condition, and usually due to mutation in the gene encoding thyroid hormone receptor beta, and this gene mutation usually inherited as autosomal dominant in 80%, and in 20% it is sporadic or due to the de novo mutation, and a little cases worldwide is due to the autosomal inherited as autosomal recessive. Actually, how to diagnose? It is simple case. Thyroid hormone, free thyroid hormone is elevated with non-suppressed TSH, and of course we can diagnose it during a neonatal screening program if we only do TSH and the free T4, not TSH alone. TSH alone cannot diagnose this case scenario because if TSH is mildly elevated, it may be subclinical or overt hypothyroidism, not resistance to thyroid hormone. So we must do TSH plus free thyroid hormones. And usually, actually, TSH resistance to thyroid hormone not more than 20. A clinical diagnosis symptom is highly variable depending on the degree of the tissue responsiveness to elevated thyroid hormone level due to the relative expression of thyroid hormone receptor beta. So with the heart, the patient presented by tachycardia because the alpha receptor is intact. And the most and main presenting symptom is goiter. The hypothalamic pituitary thyroid axis is malfunctioning, so leading to increased TSH, mildly elevation of the TSH. At the level of the ear, abnormal cochlear development, and also in the retina, affected the color vision, and the nervous system will be impaired in neural development and abnormal cerebellum and cortical layering. The patient presented by a short stature, osteoporosis, attention deficit disorder, and most of resistance to thyroid hormone is discovered accidentally. Someone doing thyroid function test, the patient is usually asymptomatic, the free thyroid hormone is elevated, the TSH is non-suppressed, so he refers the patient to endocrinologist and discovered this case scenario, especially if it is a familial. Differential diagnosis is very important, and we must put in our mind the cause of euthyroid hyperthyroxanemia. It is a very big list. The most important to exclude is thyroid function test hormonal assay, antibody to TSH or antibody الهامة antibody to free T4 and free T3, and this is well discussed in more details tomorrow, inshallah. Also, binding protein abnormality, TBG, increased TBG like during the pregnancy or oral contraceptive pills, and in some case of liver disease will affect the total thyroid hormone, not a free thyroid hormone. Also, there are some conditions, inherited conditions like FDH and TBG excess, inherited TBG excess. Also, a lot of drugs can affect the thyroid hormone like amiodarone, propranolol, and so on. And don't forget a non-thyroidal illness or the patient on already thyroxine therapy and stopped this drug. And of course, if we do full thyroid function test and from a history, we can exclude most of these conditions, but the most important is excluded TSH. This is very important, and of course, Dr. Farid شرح الموضوع باستفاضة. I will discuss it, just summarize it. A clinical thyrotoxicosis, usually the patient of TSH usually thyrotoxic, but resistant to thyroid hormone, usually euthyroid, not complaining from manifestation of thyrotoxicosis. The family history as a resistant to thyroid hormone is autosomal dominant in 80%, so it is usually runs in family, but TSH is not, has a family history. The most important is alpha subunit, usually elevated in TSH and normally resistant to thyroid hormone. And most important, not alpha subunit alone, because alpha subunit can increase in postmenopausal females, and also because the LH and the FSH have a similar alpha subunit like TSH. Alpha glycoprotein subunit over TSH molar ratio is more specific and elevated more than 1 in the TSH. Don't forget that in patient with intact thyroid, this is the most sensitive test to identify a TSH. Alpha glycoprotein subunit over TSH molar ratio more than 1. MRI pituitary, of course, TSH usually macroadenoma more than 1 centimeter in about 80%, and microadenoma in about 20%. But a resistant to thyroid hormone usually normal. But don't forget that incidentuloma, pituitary incidentuloma may be found, so founding of pituitary adenoma cannot exclude resistant to thyroid hormone 100%, because it may be non-functioning pituitary adenoma or incidentuloma. Sex hormone binding globulin usually elevated in TSH and normally resistant to thyroid hormone, and the most important is dynamic tests. One of the most important dynamic tests is TSH response to TRH. Normally, if we inject TRH to any normal patient, TSH will be elevated. But in a case of TSH, TSH will not elevated more than 1.5 fold. So a less than 1 fold rise in TSH is strongly suggestive of TSH. Resistant to thyroid hormone, usually TSH will rise more than 5 folds, and this is very important. And actually, a flat or decreased response to TRH was the most specific test to diagnose TSH. And also, TSH response to TRH had a best positive and negative predictive value, but I think TRH, this test is not available in our country. Another very important test, which is TSH response to T3, normal physiology. If we inject, if the patient receives T3, cytomel, or T4, thyroxine, TSH will be suppressed. This is normally occurred. But in TSH, if we inject or the patient received thyroxine or T3, the patient TSH will not be suppressed. In resistant to thyroid hormone, TSH will be decreased after administration of thyronine. And this actually is the most accurate test to differentiate between TSHoma and resistant to thyroid hormone syndrome. And as mentioned by Prof. Dr. Farid, it is contraindicated in the elderly, and also it is a contraindicated in a patient with coronary heart disease because it may precipitate heart attack. Lastly, normally, the ectreotide is very important. It is one of modality for treatment of TSHoma. If we inject octreotide, TSH will be suppressed in TSHoma. But don't forget that this test, acute injection of ectreotide, will decrease the TSH in TSHoma and resistant to thyroid hormone. But we must do this test for at least, if the patient receive octreotide for at least 2 months to diagnose the TSHoma versus an RTH. And of course, if you need more and more data, you can go to the European Thyroid Association guidelines published in 2013, guidelines for the diagnosis and treatment of TSHoma. So if you suspect diagnosis of resistant to thyroid hormone, you need a clinical presentation, you need a laboratory data, and finally, you need to do genetic confirmation. This algorithm is very important. If you suspect a case of resistance to thyroid hormone, you need to repeat thyroid function test. This is very important, and exclude the thyroid hormone transport defect. After that, check thyroid for thyroid hormone, thyroid function test in the first degree relatives. If normal, so it is a with TSHoma, you need to measure alpha subunit if it is elevated. So we must investigate TSHoma by MRI pituitary. But if the alpha subunit is normal, the next step is doing suppression test, T3 suppression test, or what is known as Werner test. The patient need to be administered 100 microgram oral T3 for 8 to 10 days and estimation of TSH. If TSH is suppressed, so this is a case of TSHoma resistant to thyroid hormone, and we need to genetic testing for confirmation. How to treat resistant to thyroid hormone? The most important in the treatment is to avoid diagnosis of resistant to thyroid hormone beta as a primary hyperthyroidism. Because primary hyperthyroidism, it is treated by antithyroid drug, radioactive iodine, or surgery. If you treat resistant to thyroid hormone beta by this method, the symptoms will be worsened because the patient resistance is normalized in thyroid hormone excess. This is the proposed scheme for treatment of patient with resistance to thyroid hormone beta. The first step, you must need to know that no treatment will correct the defect. No treatment is required in most patients. But in some small patients, we need to treat according to the TSH. If TSH is elevated, we can decrease it easily by administration of levothyroxine. The aim of levothyroxine in this case scenario to normalize the TSH. But the patient, levothyroxine will increase LiFR-4, which is already elevated, and the patient will complaining from tachycardia, and so we can use a beta blocker. What is most important in this case, you need to know that a dosage of levothyroxine must be guided based on thyroid hormone action, like sex hormone binding globulin, cholesterol, ferritin, basal metabolic rate, and bone density. And in most patients, if using levothyroxine, usually the patient require 1,000 microgram per day, not 100, 1,000 microgram levothyroxine daily. If TSH is normal, we look for the symptom. Why you need to treat this patient? If the symptoms possible related to thyroid, so in this case scenario, we treat symptoms of thyroid hormone excess by Triac, which is thyroid hormone analog with low biological effect and has a 3-time affinity for thyroid hormone receptor beta than T3, or DT4, which is dextrothyronine, to decrease the TSH. Dextrothyronine is available in some countries, Diagnostic in USA and Coloxine in Germany. And of course, this initiation of this drug to decrease the TSH and therefore endogenous T3 and T4, and we must add beta blocker, for example, atenolol in a dose of 25 to 100 milligram daily. And if the patient symptomatized by manifestation of thyroid hormone deprivation, so it is easy to treat it with levothyroxine. But if there is no symptoms related to thyroid, we look for the family history of adverse outcome. If this patient have another sister or brother with low IQ or aggressive problem or developmental delay, in this scenario, we must treat by levothyroxine to maintain TSH close to 1 microgram unit per milli. If no, so no treatment. So in most our patients, no treatment is required in most patients. This is very important if there is a goiter and the goiter causing a manifestation for a patient of resistance to thyroid hormone beta. The goiter can be reduced by administration of a single high dose of liocyanine, Cytomel, given every other day. The dose of liocyanine should be titrated, but can be as high as 250 microgram per dose. Lastly, we just two slides about resistance to thyroid hormone alpha, which is a very rare disorder just discovered since 2012, caused by heterogeneous loss of a mutation in thyroid hormone receptor alpha gene. And usually the patient presented by low free T4, normal or slightly elevated free T3 with normal or slightly elevated TSH. The patient have a very low reverse T3, and the most pathognomonic is high ratio of free T3 to free T4 or low ratio of free T4 to free T3. The patient usually phenotype varies in severity but is constant with a manifestation of untreated congenital hypothyroidism in the peripheral tissue, especially in the tissue with the dominant role of thyroid hormone alpha like bone. The patient presented by delayed development, short stature, and a chronic constipation, and this is usually presented in the early life, impaired neural development, abnormal cortical layer and cerebellum development, and in a level of the heart, the patient usually presented by bradycardia. And this case is just discovered since 10 years. How to treat resistance to thyroid hormone alpha? It is easily treated by replacement therapy by levothyroxine. Here, as we know that T4 is low, so we can replace it by levothyroxine. Actually, this table summarizes all my presentation, all thyroid hormone impaired sensitivity to thyroid hormone. Anyone can capture this image and review it. I reach take-home message. My take-home message: resistant to thyroid hormone is a rare autosomal dominant inherited syndrome, most cases due to the mutation in the thyroid hormone receptor beta gene. Resistant to thyroid hormone usually asymptomatic, discovered by elevated thyroid hormone with non-suppressed TSH. Common clinical features are goiter, short stature, with absence of usual symptoms of thyroid hormone excess. The most important differential diagnosis is TSHoma after excluding the factor leading to elevated thyroid hormone. No treatment is required in most cases. Thanks.
دكتور خالد، بنشكر حضرتك على المحاضرة الأكثر من رائعة. فعلا كل شيء لوجه الله. ربنا يكرمك يا دكتور خالد على المحاضرة دي. أكيد أخذت من حضرتك مجهود جامد جدا في تحضيرها. اللي أنا عايزة أقوله بعد سماع المحاضرة الجميلة دي إنه يا جماعة من فضلكم لما حد يلاقي الثايرويد فانكشن يعني فيها حاجات مش الكلاسيكال اللي إحنا متعودين عليه، يا ريت نبعتها لحد